Hey Bems, it's Bryan here. Let's take a few minutes to talk about basic airway. Our soft and hard skills airway sessions are coming up in August, micro and macro sessions. And remember, we're accountable for everything we've gone over from day one up through airway. So be prepared. Let's get to work. Let's get our legal time out there. So disclosures, I'm not your medical director. I'm not telling you what to do. I'm not giving you medical advice. And I have some financial disclosures as well. All right, let's talk about clinical pearls. All right, from my career, I can basically say these things: slow is smooth and smooth is fast, especially when it comes to airway. 2 is 1, 1 is none. Be prepared, anticipate what's coming, which brings us to proper planning prevents death. As a medical director in Bucks County, I've seen perfectly healthy people that EMS initiated an airway on who died and became organ donors. It's not funny. When you're managing an airway, especially if you're going to initiate an airway, you have to be foundationally sound to be able to manage an airway. Otherwise, you're literally initiating death. And remember that the basics are the foundations on which success is built. If you cannot manage a basic airway, it's just like hemorrhage control. Then you don't have the foundation you need to be doing any advanced airway. This seems to, in my experience, always be inverted in EMS and emergency medicine. People want to do all these advanced things, but you can't manage a basic airway. Remember, basic airway skills is all you need to manage anyone, really. So let's make sure we crush these basics and move on and do some fun training on the micro and macro sessions. When it comes to progression, just like everything else we've done, it's a crawl, walk, run, and we're doing steps, right? Everything we do is a next step up. So basic anatomy, just like in hemorrhage control, is absolutely paramount in order to have a great foundation of airway management. Which brings us to, when you understand anatomy and how that works, positional airway techniques are really all you need. You can literally manage an advanced airway. But again, advanced airways allow us to do things like have both our hands free, put someone on a ventilator, etc. Basic airway adjuncts, how do they help us? How do they hurt us, right? What does an MPA do for us? How does it harm us? What's an OPA do for us? How can it harm us? These are critical questions you're going to have to answer. And then we're going to move on. Once we have the basic airway positional techniques, basic airway adjuncts, we're going to go on to the ventilation adjuncts, right? BVMs, other airway adjuncts if we get to them for the advanced provider. And then we get to our advanced airway adjuncts again. How does it help us? How does it hurt it? How does it fall within protocols and SOPs? And how do we secure an airway? And how do we do facilitated airways if we get there? We can also talk about procedural sedations in regards to how they can be done in advanced EMS. But hopefully we can get through these basic anatomy, positional airway, basic airway, ventilation adjuncts, advanced airways, and have some experience doing digital airways, tomahawk airways, inverted airways, closed space airways, so we can grow our foundational knowledge and feel more comfortable with just the basics. But remember, we're doing the more advanced, enjoyable things like tomahawks because I think they help us with a foundational understanding, not because we should be doing them in the field. And when we talk about understanding anatomy when it comes to hemorrhage control or anatomy when it comes to airway, it's just absolutely critical that you can close your eyes and literally see what an airway would look like without having a cross section. At the end of this PowerPoint, we have a video link that really gives you a good idea of how to fly through an airway. But basically, if you can close your eyes and visualize an airway to include the epiglottis, the glottis, the oral pharynx, the tongue, the soft and hard palates, how the airway is anterior, and these types of things, then it makes it much easier for you to understand how to navigate passing an airway, whether it be a nasal airway, an oral airway, a direct laryngoscope, a video laryngoscope, changing your anatomy as it relates to where you're standing in relation to the patient, meaning, in other words, digitally intubating them when you're standing in front of them versus a tomahawk when you're standing in front of them versus when you're working from the head in a typical DL type situation. You can't really do these things unless you really understand the anatomy. And inversely, understanding the anatomy really helps you do the very basics. So make sure you can answer any questions and that you can close your eyes and visually fly through an airway. And when you can do that, then I guarantee you can manage any airway much more effectively. As EMS practitioners, we have to understand the difference in each patient, the infant versus the child versus the elderly versus the Down syndrome person or the person that has a fragile cruciate ligament, someone who's been a result of penetrating trauma versus blunt trauma. We have to understand all these things innately and how they impact the way we would manage their airway. So as we show up for our micro sessions, let's make sure we crush the basics, that we can close our eyes and fly through an airway. We understand and can actually conduct a proper head tilt chin lift and do it at the right time for the right reasons. Also know how to execute a proper jaw thrust, right time, right reason. How we can manage airway positionally, and we discussed that in managing patients during hemorrhage control. And remember, the most important thing, the pearl that everyone must take away, is that airway management is about ventilation. It's not about intubation or oxygenation. You can die with 100% oxygenation of ventilation failure, right? And that's a common thing people just don't grasp. Even advanced providers sometimes just don't get it. I've heard trauma surgeons say their airway's fine. They have 100% pulse ox, and it's like, wrong. Get your money back, right? That's not correct. You can die of hypoventilation with 100% pulse ox, right? And you can properly ventilate someone and not have optimal oxygenation numbers. And we can also understand things like, our oxygenation as related to pulse ox will be the last indicator if someone's lost their airway or not being ventilated properly, and all these basic things that we'll talk about. But remember, head tilt, chin lift, jaw thrust, proper airway positions, and remember, management of airway is about properly ventilating someone. Here's our basic reminder slide about different positions, making sure we put someone in a proper position, that their airway is innately open. Right now it won't always be open, but of course it's much easier to ventilate someone and put them in an open airway position and bag valve mask them effectively if they are set up for success by being in the proper position based on their age, their weight, their shoulders, other anatomy type issues like maybe Down syndrome or kyphosis, and all these things that we learned in basic school. We're going to challenge you and hope that we get them first shot so we can move on to more advanced and interesting things. Let's make sure we know our basic adjuncts. Adjuncts in airway are just like adjuncts in hemorrhage control or any other thing. They're a stopgap measure and something to replace your hands so that you can do other things. So putting an NPA in, understand how they help, how they can hurt. In other words, relative contraindications, and when they're indicated, and understand why you're doing it, which is basically so you can free your hands up so you don't have to be as hands-on to keeping an airway open. Just like our MPA, we have our OPAs. How do they help? How do they hurt? What are absolute things you never do with an OPA? What are things that help you do an OPA? You know, how you put them in appropriately. These are things you need to know. They're basic foundational things, but we actually find as we train people around the world that even these basic foundational things sometimes aren't done properly, weren't trained properly originally, or you get kind of lazy, or someone is, you know, calcitrant to learning new techniques or the appropriate techniques. So make sure you know how to measure an OPA, when it's indicated, when it's contraindicated, how it helps, how it can hurt, things you do, things you never ever do when it comes to OPAs. I have to tell you, we're going to hit this pretty hard because in my years of doing this, it's something that just continuously comes up, even with very advanced providers. And that's how a bag valve mask works, how it can help you, how it can actually hurt your patient. And we're going to talk about that and the difference between a bag valve mask and like an airway management mask that you would see in anesthesia, which does not have a valve and has flow monitoring. So for us in EMS, we use bag valve masks, and we must know how they help, how they work against us, how to use them in a one-person technique, a two-person, how to use them when the person's sitting up, how to do it when they're supine, and all these other types of techniques we'll go over. But make sure you understand the absolute foundations of how they help, how they can hurt, and how they work. So if you don't take anything else away other than the foundational information of anatomy, physiology, and positions, I think one of the most important things that you can take away from this class, which I've again seen through the years, which is people don't understand that bag valve masks do not and cannot provide passive ventilation. In other words, if you seal a mask on someone or if you don't compress the bag, the valves close and it doesn't work. If you don't believe me, try it yourself. Take a bag valve mask, seal it to your face, and try to breathe, and you'll see it doesn't work. And I guarantee you'll never do it to a patient again. So we'll talk about that. Somebody will be a guinea pig, and we'll actually maybe do it in a lab. And then remember that anesthesia devices, that's not how they work, right? So when you get a class from an anesthesiologist or a nurse anesthetist, it's critical to understand that if they may be talking about an anesthesia mask or other type of mask, but for us in EMS, we use bag valve masks for very good reason. Understand how they work, how they don't. They have a valve. If anyone's telling you to passively oxygenate someone with a bag valve mask, they don't know what they're talking about, or they are misspeaking, or we are misunderstanding them. So if you have a few minutes, take a look at these videos. I call them the good, the bad, and the ugly. For those that are my age or older, you'll know that reference. But basically, you know, our first video is the good, and the video is airway management shown as a calm, cool, collected, professional airway done by an old guy with gray hair who's an anesthesiologist teaching at Harvard, I believe. And it's a really great video to show what's possible, and it shows anatomy really well. So take a look at it. It's fun. You can fast forward till you start to see them do some cool stuff. And then there's the not good airway. You know, there's plenty of these to put out there on YouTube, but you know, if you want to get through this one. But I'll be honest with you, this is the airway I see more often than not when I observe field EMS airways, and it's minimal or below minimal practice, you know. So it's too long, no pre-oxygenation, tremendous trauma, definitely what you do not want to emulate. So the good, the bad, the ugly. Check it out if you got time. All right, so the basic airway summary that we're going to be going into are hard skills, soft skills, micro and macro sessions in August. Everything builds, so there'll be trauma and airway and positional and evaluations and everything else going on simultaneously. But remember, slow is smooth, smooth is fast. Remember, basic airway management is foundational. If we do not understand it, we will be less than optimal airway managers. Adjuncts are helpful, but technique is critical. Adjuncts are just there, again, like any other adjunct, to replace your hands. You should absolutely be able to manage an airway perfectly with technique without even requiring any adjunct other than a BVM, because of course we're not going to do mouth-to-mouth in our profession. Ventilation, not oxygenation, is the goal. Remember that. You can die with 100% oxygenation. Now, of course, we want to oxygenate people appropriately, but the key to this is ventilation, right? If you're ventilating someone properly, even on room air, you will be oxygenating them most likely. And with, you know, supplemental air and oxygen, you'll definitely be able to do so. Be prepared to masterfully handle the basic airways in our micro and macro session, so we can blast through the basics, identify what we can work on to best improve to be that absolutely elite teammate. And remember, excellence is not an art, it's a habit. We must be disciplined with our plans. All right. Every habit, every choice, every standard shapes the outcome, and we make a decision every day who we're going to be and how well we're going to perform in our art. All right. Hope you enjoyed this. Doc out. As usual, we got to talk about the lawyers. So I am not your medical director. I'm not giving medical advice. We're just two professionals having a discussion. And it's important that we note that, given this will be open content.